everybody. I'm Mrs. Princey, Associate Professor in Mental Health Nursing. There was a woman named Margaret who was 68 years old who had lost her husband to 45 years old 6 months ago. The husband died because of a massive heart attack. They had no children and had been inseparable. Since her husband's death, Margaret had keep on visiting the cemetery and changing the flowers on the grave very often. She had not removed any of his clothes from the house in the closet, and his shaving material still occupied the place in the bathroom. Over the months since then, Margaret had become more and more socially isolated. She refuses invitations from her friends and family, instead make her daily trips to the cemetery. When her sister-in-law visited her house, she discovered that Margaret had lost almost 15 pounds of weight and had no food in the house. Sister-in-law failed to get anything for her to eat because Margaret was refusing to take the food or anything for that matter. Margaret also shared to her sister-in-law that she didn't want to live anymore. Her life was nothing without her husband, Frank. Hearing this, her sister-in-law was frightened and understood that Margaret needed her help from the psychiatric unit. So her sister-in-law brought Margaret to the psychiatric ward for the assessment and the diagnosis. Yes, what do you think is the diagnosis of Mrs. Margaret? Yes, you're right. So the diagnosis here is the depression. Margaret suffered from depression and was put on the treatment. The topic which I'm going to talk today is about the depression. What do you understand by the major depressive disorder? The major depressive disorder is also termed as the clinical depression, which is the most common psychiatric disorders. It is estimated to affect about 15% of the population. Major depressive disorder impacts the person's mood, cognition, and the behavior. Let us see the meaning of depression. Depression is a mood disorder which is characterized by persistent feeling of sadness and also loss of interest. It is also termed as major depressive disorder or the clinical depression, where it's going to affect the person in terms of his feelings, in terms of the thoughts and behavior, which is going to lead to a variety of emotional as well as the physical problems, right? So this is the meaning of depression, wherein you can find that the person is having a persistent feeling of sadness, loss of interest, and also there will be alteration in his thinking and emotions, wherein the whole personality of an individual seems to be depressed. Let us see the types of major depressive disorder. So we have got a list of the types of major depressive disorder. Number one is the seasonal affective disorder. It is called as SAD, S-A-D. The second one, we have the psychotic depression. The third is the postpartum depression. We've got the melancholic depression, catatonic depression, bipolar disorder or the depression, and we have got the persistent depressive disorder. Let us see each of it in detail. The first one is the seasonal affective disorder, the SAD. Yes, as the name says seasonal, you can notice the depression in the people in certain months or in certain seasons, especially during the winter months. You can notice that because of the season or because of the changes in the climate or weather, the person's mood also becomes very depressed, or he feels very sad or low. Okay, so which happens only during certain seasons, especially during the early winter months. However, his mood is going to lift up during the spring or the summer season. So this is about the seasonal affective disorder. The second one is the postpartum depression. So postpartum depression occurs in the women who have recently given birth, right? So you can see, especially in the first time mothers or the new mothers who would have also had some postpartum blues. Here, the mother will have the feelings of sadness and anxiety for a persistent period of time. So especially the mothers who are very new, the new or the first time mothers will be very much anxious about the care that has to be given to the child, how they have to care for themselves, how they have to manage their home. So all this is going to create a certain imbalance. And also during the postpartum period, there are a lot of changes in the hormones or endocrine system that happens, which can be the cause why the mother will have all these symptoms which she is going to experience as the depression, right? So that is about the postpartum depression. The next one is the catatonic depression. So here the client will have the depression along with the features of depression. There are certain catatonic features which are noticed, like muscular rigidity, motor difficulties, or the stupor. The next one is the bipolar disorder. So in the bipolar disorder, as I told you, it is the condition where you can find out the two disorders. One, continuum, there is depression. The other continuum, there is mania. So when the person is having bipolar affective disorder, it can be with the current episode depression. So we have BPAD with the current episode depression, wherein the person will exhibit symptoms of the depression. So we can say the person will experience the episodes of low mood, which is called as PPAD depression. The next one is the persistent depressive disorder, which is otherwise called as dysthymia. So it is a condition which happens in the client where there is episodes of major depression accompanied with periods of less serious symptoms, right? So this kind of symptom that you see in the client will be persisting or must be present in the person for about 2 years continuously. Persistently, the person should experience these features. That is a major depression with a milder symptom. So that is termed as the persistent depressive disorder or the dysthymia. So this is about the various types of major depressive disorder. Moving on to the ICD-10 classification of depressive episode, we've got the chapter F32, which completely describes about the depressive episode. F32.0 talks about the mild depressive episode. F32.1 is the moderate depressive episode. F32.2 is the severe depressive episode without the psychotic feature. F32.3 severe depressive episode with the psychotic features or the symptoms. F32.8 other depressive episodes, that is the atypical depression. F32.9 depressive episode which is unspecified. F33 which is the recurrent depressive disorder. So this is the classification according to the International System of Classification of Disorders. The chapter which is talking about depressive episode is F32. Moving on to the etiology or the reason why a person ends up with a depression. Number one reason is because of the biochemical factors. So there is an influence of the neurotransmitter in the emotion or in the mood. So whenever there is an imbalance or disturbance in the level of the neurotransmitter, there are changes which is going to happen in a person. In case of depression, it is found that there is deficiencies of some of these neurotransmitters, that is noradrenaline, serotonin and dopamine in the few or some areas of the brain. If you take the neurotransmitter dopamine, so dopaminergic activity will be very much reduced in case of depression, whereas in mania, the dopamine activity will be a little higher. Right? So these are the changes that you can notice at the level of the neurotransmitter or the biochemicals. The other reasons why the person ends up with depression can be because of abuse of certain drugs or alcohol, because of the physical illness, or it can be also because of the side effects of certain medications that the person is taking for a very long time as a chronic, medications for chronic disorders. So what are those physical illnesses wherein the person is more prone or is at risk for developing the depression? Number one is the viral illnesses, frequent viral illnesses, carcinomas, neurological disorders, endocrine disorders, especially the thyroid disease, hypothyroidism is closely related to the depression, multiple sclerosis, pernicious anemia, diabetes mellitus, systemic lupus erythematosus, Addison's disease. So if you take the drugs, okay, if the person is using these drugs for a longer period of time, or because of the side effects of these drugs, the individual is at risk of developing the depression. Those include analgesics, antidepressants, antihypertensives, anticonvulsants, benzodiazepine drugs, as well as the antipsychotic drugs. So as I told you, the endocrine factors, especially seen in the hypothyroidism as well as the Cushing's syndrome. What is the next etiological factor which is contributing to depression? So we have got the genetic factor. There is an increased risk for an individual to develop the depression if there is a family member who has already been affected with the depression. Okay, the family history of depression is a major genetic factor which can contribute for an individual to develop the depression. The next theory we have is the circadian rhythm theory, which is closely related to the depression. Circadian rhythm is very much responsible for the sleep-wake cycle, for regulation of hormones and activities in an individual. So if there is a disturbance in the circadian rhythm, it can result in the depression. Now, why there may be changes in the circadian rhythm, sleep-wake cycle, changes in the hormone? Why? It can be because of the influence of certain medications that the person is taking, or it can be because of nutritional deficiencies, can be because of physical or psychological stress or the illnesses, and also because of the hormonal fluctuations. So these are the changes which is going to contribute to the disturbance in the circadian rhythm, which is again an important cause for the depression. The next one is changes in the brain anatomy. If you take the brain of a depressed patient, you can notice that there is a change in the structure of the brain. So what is the change? There is a loss of neurons in the frontal lobes, cerebellum, as well as the basal ganglia. So these are the So these are the areas wherein there will be loss of neurons, which is going to contribute to the depression. The next one is the psychosocial theory. So in the psychosocial theory, we have got a very important theory, which is the psychoanalytical theory given by Sigmund Freud. Sigmund Freud says that depression results because of loss of loved object. So, if the person experiences the loss of a loved object, it can be related to a person, to a situation, or to a thing, whatever it is that he loves so much that he loses, it can result in the depression. The second thing what he says is fixation to the oral stage or oral static stage of the development. If a person is having a poor milestone development, he fixes to the oral stage of the development, then a person will not be able to develop the good ecosystem. He will not be able to develop the coping mechanisms which can contribute to depression. The third thing is mania is viewed as a denial of depression. Okay, sometimes there are conditions wherein the individual is actually depressed, but to the outside world, they don't seem to be depressed. Okay, we call it as smiley depression, where an individual always keeps on smiling, he feels very joyous, he feels very, energetic. Okay, so which actually shows to the external world that he is very hyperactive. But when it comes to the internal world or internal aspect of the individual, he is very isolated, he feels very lonely, which is the person's coping mechanism which the individual is using of denial of depression when he shows the manic symptoms. Okay, so this is the psychosocial theory. The next theory which explains the reason why a person develops depression is the behavioral theory. If the person is experiencing repeated failures in his life or repeated losses in the past life, right? A person can end up with a depression. It can be loss of loved one, loss of loved object, or loss or failure in the examination. Continuously he fails in a particular task. Okay, so that can be a reason why a person ends up with a depression, because repeatedly a person is facing the failures and the loss. Obviously, the person may not have the coping mechanism to cope with it, leading to depression. The next theory is the cognitive theory. So, cognitive theory explains that depression results because of negative cognition. So, when it comes to the negative cognition, it can be negative cognition of the environment, negative cognition of his own self, negative cognition of others. So the overall cognition or the thought it can be a thought of helplessness, hopelessness, worthlessness of his own self. Or it can be related to the environment. He will relate everything to what happens to the environment to himself. So, for example, in the family, if there is anything, untoward which is happening, he will relate that environment to himself. Okay, he may just have the negative thought that whatever bad things which is happening around his environment is because of him. That he is the reason why all these things are happening. He feels very guilty and he feels very sad for it. Right? So negative cognition towards the environment or negative cognition of others. So the very thought or the cognition itself is a negative thought or the pessimistic way of thinking. If the person is having, it can result in the depression. The next factor is the environmental factors, otherwise we can call it as social factors. There are certain specific events which happens around an individual or the situational stressors which can make the person to end up in a depression. For example, it can be the death of the loved person, certain kind of abuses like sexual abuse, physical abuse, all these are going to contribute to the depression. So these are the reasons why a person ends up with the depression. Now, moving on to the psychopathology. What is the reason or how is the disorder going to progress? So, we have got some theories or the hypothesis which is going to explain the psychopathology of the depression. Number one is the biogenic amine hypothesis. We have got the receptor sensitivity hypothesis, the serotonin only hypothesis, the pervasive hypothesis, the electrolyte membrane hypothesis, and the neuroendocrine hypothesis. So let us see each of these hypotheses in detail. The number one is the biogenic amine hypothesis. According to this theory, they say that depression results due to the deficiency of the bioamines or the monoamines. Now, what are these monoamines? These are nothing but the precursors of the neurotransmitters, that is noradrenaline and the serotonin. So, if there is a deficiency in the neurotransmitter, there is noradrenaline as well as the serotonin, it can lead to depression. So, that is what the bioamine hypothesis explains. And also, they give the treatment based on these neurotransmitters. If the reason is because of this and the person is getting treated to improve his bioamine levels, the symptom relief can be noted not lesser than 6 to 8 weeks. So you can say that when the antidepressant drugs are given to such kind of a patient, it will take almost 1.5 to 2 months to see to it that the symptoms of depressions have reduced, right? So that is the bioamine hypothesis. The second one is the receptor sensitivity hypothesis. So you understand receptor sensitivity hypothesis. If you take the neurotransmitter structure, you've got the receptors on the postsynaptic neuron. So these receptor sites have got the sensitivity issues. You know very well that receptor sites are the sites where the neurotransmitters comes and they get attached onto. In depression, what happens? There is an alteration in the receptor site. So what is that alteration? There is supersensitivity and upregulation in the receptor sites. Okay, so what happens when the antidepressant drugs are given? So you know the classification of antidepressant drugs, so especially the TCAs as well as MAOI group of drugs, when it is administered, it is going to act on these receptor sites. So now in depression, what is the reason? There is a supersensitivity, upregulation which is happening. When TCAs or antidepressants which belong to monoamine oxidase inhibitor group of drug is administered, these sensitivity sites are going to undergo a downregulation, wherein this receptor sites will decrease in the number. Right? So that is the thing which happens when the antidepressants are given. So this theory completely explains that there is going to be an alteration in the receptor side, that is a super sensitivity or the hyperregulation, because of which the person is undergoing the depression, and that is going to be treated by these antidepressant drugs. The next psychopathology is related to the serotonin-only hypothesis. So according to this hypothesis, they say that there is no influence or there is no role of the noradrenaline in the depression. They say that it is only the serotonin which is responsible for the depression. Even though this theory explains that only serotonin is having the role in causing depression, it has got some drawbacks. It does not explain why there is a delay in the onset of clinical relief. So even though you give certain antidepressants which is going to boost up the serotonin level, it does not clearly explain the reason why there is a delay in the relief of the symptoms. The second failure is it does not completely explain the role of noradrenaline as to how this is not contributing to the depression. So the serotonin only hypothesis states that it is only because of serotonin a person ends up with the depression wherein there is a deficiency of the serotonin. The next hypothesis is the permissive hypothesis. According to the permissive hypothesis, they say that the control of emotional behavior results from a balance between noradrenaline and serotonin. So if a person wants to have a balance in the emotional behavior, it is the role of two neurotransmitters. One is the noradrenaline as well as the serotonin. If the serotonin and the noradrenaline level goes down, or there is a deficiency of serotonin and noradrenaline, the person will become depressed. If the serotonin level is low or decreases and noradrenaline level is considerably high, the person ends up with the mania. So they say that both these neurotransmitters, that is the noradrenaline as well as serotonin, are contributing for an emotional behavior of an individual. If the serotonin and noradrenaline goes down, the person ends up with the depression. If there is a high level of noradrenaline, low level of serotonin, the person ends up with the mania. So that is what is a permissive hypothesis. Next is the electrolyte membrane hypothesis. As the name says electrolyte, we have got certain electrolytes which are going to contribute for the mood disorders. So they say that hypocalcemia may be associated with mania and hypercalcemia is associated with the depression. The last hypothesis is the neuroendocrine hypothesis, which explains that any changes that happens in the endocrine system, alterations in the endocrine system, can result in the emotional disorder or the mood disorder. Right? So these are some of the hypotheses which is going to explain the pathophysiology of the depression. Moving on to the clinical features. So what are the clinical features of depression? The following symptoms should be present in the patient at least for a period of 2 weeks continuously to make the diagnosis as depression. So what are those clinical features? You have got a mnemonic here, which is the SIG-E CAPS, right? So what is it? There will be sleep changes, loss of interest, worthlessness feeling, that is feeling of guilt, lack of energy, poor cognition or poor concentration ability, disturbance in the appetite, disturbance in the psychomotor level, as well as the person will have the suicidal ideas. So these are the general symptoms which is present in the person. So if these symptoms are present in the person at least for a period of 2 weeks, then you can make a diagnosis of depression. So let us see the clinical features in detail. The first thing we have is a depressed mood. So depressed mood is the feeling of sadness, or it can be loss of interest in almost all the activities, and also loss of pleasure in almost all the activities. Say for example, earlier the patient or the client loved to watch the movies or loved to watch the programs on the TV. But now if you go and play a movie, favorite movie, even then she doesn't get any kind of a pleasure or she doesn't feel happy. Say for example, an individual love to do gardening, right? So but now if you take the person to the garden also, it's not going to get any kind of a pleasure or happiness out of it. So that is what is changes in the mood which happens continuously. There is a feeling of sadness, loss of pleasure, loss of interest, which is termed as pervasive sadness. And if this kind of a depressed mood is present in the patient throughout the day, it is termed as the persistent sadness. There are certain conditions in depression wherein, early in the morning the person feels very sad, but as the day, moves on, and when there is a little brightness which comes over the day, right, the person's mood also feels better, right? Unlike that, if a person is having the depressed mood continuously, persistently from morning till the night, then we term it as depressed mood. The next symptom is the depressed cognition. If a person is having feeling of hopelessness, so he feels no hope about the future. Second is helplessness. The person feels that he cannot seek help for anything from anyone. Feeling of worthlessness, that is nothing but feeling of inadequacy or inferiority. Unreasonable guilt without any reasons. Okay, he feels very guilty. He blames himself. So that is termed as self-blaming, even over the trivial matters of the past. Okay, even for these small mistakes which happened, he blames himself, right? So these things are termed as the negative cognition or depressed cognition. We have got the symptoms of helplessness, hopelessness, worthlessness, unreasonable guilt, and self-blame. The next symptom is the suicidal thought. Very, very important. When a person is having a very severe form of the depression, it will be associated with the suicidal thought or suicidal ideation. So a person continuously feels the feeling of hopelessness. He will develop the idea that it's not worth living anymore. So as a coping mechanism, he ends up with the suicide. So these kinds of thoughts will provoke the person to plan for the suicide, especially the ideas of hopelessness and the worthlessness. The next symptom is the psychomotor activity. If you take the psychomotor activity in a depressed person, it seems to be retarded. All the areas will be retarded in terms of retarded thoughts, retarded psychomotor activity, that is, even his walk, the way he performs his activity, everything seems to be very slow or very much retarded. So how do you understand the person is having retarded thought? So when you go and talk to the person, when you communicate to the person, by the way he talks itself, you can make out that he is having a retarded thought. It takes a very long time to respond to you. Sometimes he may not even respond, right? So he will be having a very monotonous voice. Is it just moves his lips without uttering or without producing the sound. He may not maintain the eye contact. So all these symptoms makes us to understand that he's having a retarded thought. If you take the older patients, the depression symptoms seems to be seen in a different way. They seem to be more agitated, anxious, restless, and will have the feelings of uneasiness. So these symptoms you can notice in the older clients. So the next clinical feature is the psychotic feature. So what is the psychotic feature? Along with the depression, the person is having the symptoms of psychosis, that is delusions and hallucination. We call it as psychotic depression. For example, if a person is having nihilistic delusion, he feels the non-existing of the world or the surrounding, right? So, or he may have the delusion of guilt, delusion of poverty. All these makes us to understand the person is having psychotic depression, that is the symptoms of psychosis plus the depression. So if you take this kind of the condition, that is psychotic depression, the prognosis is very poor because there is a combination of the two disorders, which is psychosis as well as the depression. Okay, sometimes there will be delusions like delusion of control, wherein he feels that all the actions or whatever his thoughts are being controlled by someone, right? So, or delusion of command, which just commands him to do, or he may just hear, the voices, right? Or hallucination, auditory hallucination to kill himself or stab himself or take a knife and cut his vein, which is again going to result in suicide, right? So that is a combination of the psychotic features and depression, wherein the prognosis is very poor. Moving on to the somatic symptoms in depression. So in the depression, it's not only the feelings, emotions, changes in the psychomotor activity or thoughts. There are certain somatic features that you can notice. So these features, when it is present, it is termed as melancholic features. The symptoms of somatic features are termed as melancholic features. Number one, significant decrease in the weight or appetite. There may be the early morning awakening, that is 2 hours or lesser than 2 hours of wakening early compared to the usual waking time. There may be diurnal variations that is especially seen in the early morning. So as I told you, beginning of the day, the person feels depressed. As the days move on, okay, he feels better. So diurnal variations can be seen. Pervasive lack of interest and lack of reactivity to pleasurable stimuli. You can also notice psychomotor agitation and restlessness. So these are the somatic features or melancholic features that you can notice in the depression. Moving on to the other features. One is the difficulty in thinking as well as concentration. There may be poor memory. The person verbalizes that he is having a very poor memory. There may be menstrual or sexual disturbances. If in case of female, there is a hormonal changes which can contribute to the menstrual changes or disturbances in the menstrual cycle. There may be difficulties with the sexual functioning. There may be vague physical symptoms which are noted like fatigue, body aches, discomfort, constipation. So such kind of features that you can notice in the other features. Moving on to depressive symptoms in children. So if the children, it's not like only the particular age group will develop depression. No, it is almost in all the age group. You can notice even in the childhood period, especially if you take the teenage period also, the older age group, all the age group almost can be can develop the depression. So if you take the depression in children, so what are the symptoms that you have to be very careful to notice? Number one, the child will have the sadness. So he simply sits without doing anything, sits alone, sits very isolated, not interacting with the family or friends. You can understand some warning sign. Next is the irritability. The child will get irritable very easily, okay, very quickly he gets irritable even for small matters. There may be the behaviors like clinging. So the child may cling on to a parent or to his loved one when he doesn't want to just move out, right? So it can be because of it he had a very bad experience, he doesn't want to leave, okay, or he may be having the previous loss, okay, in his life, which can result in such kind of a behavior of clinging on to the loved ones. Refusal to go to school is another symptom that you can notice. If the child is depressed, he doesn't feel to go to school, he doesn't want to go anywhere for that matter, he just sits in one place alone. And the next one is being underweight. So being underweight is another symptom. It doesn't eat, its appetite is very poor, there may be loss of weight or underweight. So these are the symptoms that you can notice in the children. So if you take the teenage group or the adolescent groups, the symptoms of depression are different. Here the adolescent is a period wherein there is a spurt in the hormones, okay, there are changes which happens in the physical aspect as well as the physiological aspect. A lot of changes in the hormones and fluctuations can result in the symptoms, right? So one is he may exhibit the feeling of anger, feeling negative and worthless, poor performance in the school or in his various activities, poor attendance in the school. Always he may feel the feeling of being misunderstood, or he becomes very much sensitive. He may start using the drugs or alcohol, which may become the abuse to drugs and alcohol. As a recreation, he starts using a coping mechanism for depression, negative coping mechanism that he may develop as a recreation. He may start using the alcohol, abusing the drugs, which later on he will become abused or addicted to. Eating or sleeping too less or too much, right? Again, insomnia, hypersomnia, or loss of appetite, overeating, binge eating, being obese. So all these also contributes to the depression. Loss of interest and avoidance of the social interaction. It can be related to get together or family function or anything the adolescent tries to avoid. So these are the features that you can notice in the adolescents. Moving on to the depressive features in the older age group. The older adults may have difficulties in the memory. He may complain of physical aches and pains, sleep problems or loss of interest in the sexual functioning, loss of interest in the socialization or in various activities, suicidal thinking of feelings, especially in case of older men, right? Thinking can be pessimistic, sometimes suicidal. So you understand during the old age period what happens. It is a period of retirement. Okay, so it is a period wherein there may be financial difficulties for the client, or it is a feeling of incompletion of the life task. He may not be satisfied with the earlier life that he had, or he may have the feeling of a burden that is burden to his children, or the children would have neglected the old parent. So all these put together can result in depression, which can lead to the pessimistic way of thinking or suicidal ideations. In case of severe conditions, even the psychotic features can be noted, that is illusions and hallucinations along with the depression. You can notice insomnia, hypersomnia, loss of libido, weight loss or loss of appetite. Overall intellectual and cognitive symptoms that you can notice are decreased ability to concentrate, slowed thinking, poor memory of recent events. So all these can be seen in the older age group. So this is the symptoms or clinical features of the depression, right? So moving on to the diagnosis. So how do you diagnose depression? The first thing is you're going to do a mental status examination. You're going to collect the history. You're going to do the mental status examination. So based on the assessment, what you do, you're going to have ICD-10 classification to classify the type of the depression, whether it is mild, moderate, severe type of the depression. You're going to notice for the usual symptoms like depressed mood, loss of interest and enjoyment, reduced energy leading to easy fatigability, as well as diminished activities. So these common symptoms that you are going to notice: reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and feeling of worthlessness, bleak and pessimistic views about the future, suicidal ideas, suicidal acts or self-harm, disturbance in the sleep, as well as diminished appetite. So these are the symptoms that you are going to notice when you do a mental status examination, and based on the ICD-10 classification, you can classify the depression as mild, moderate or severe. So what is a mild depressive episode? Here the person should have at least 2 usual symptoms and 2 common symptoms for a period of 2 weeks. Then you diagnose the person as having a mild depression. The moderate depression, again here the person should have 3 or more usual symptoms as well as 3 or more common symptoms at least for a period of 2 weeks. Then you put the person under the moderate depressive disorder. When do you tag a person as severe depression? Okay, if the person is having 3 of the usual symptoms and at least 4 of the common symptoms, which is of severe intensity for a period of 2 weeks, then you're going to put him under the category of severe depressive episode. So these are the classifications that you can make based on the symptoms of usual symptoms and the common symptoms. Moving on to certain investigations, we have got the rating scales. So based on these rating scales, you can rate the type of the depression, whether it's mild, moderate, severe. The grading of the depression can be done based on these rating scales. Number 1 is Beck's Depression Inventory, and we have got Hamilton's Depression Rating Scale. So based on these rating scales, you can grade the type of the depression. Okay, and when you start the treatment for depression, you use antidepressant drug or you use psychotherapy or ECT, whatever the treatment modality that you use. Again, you make use of these rating scales to see whether your treatment is bringing about improvement in the symptoms, wherein the grade of depression can be changed. Right? So this rating scales are very important to know, to categorize the degree of the depression, and even after the treatment, which category the person belongs to. Right? Whether there is an improvement, there may be changes in the type of the depression. The next investigation that we do is dexamethasone suppression test. When you do a dexamethasone suppression test, it shows there is a failure to suppress the cortical secretions in case of depressed patients, right? So usually when this corticosteroid dexamethasone drug is given, the cortisol level should decrease. But in case of depression, the cortisol level remains the same. There is no decrease in the cortisol level. Failure to suppress the cortisol level happens, which is the dexamethasone suppression test. So if there is a problem related to the endocrine system, the reason why a person ends up with depression, when you do this dexamethasone suppression test, you notice that there is a failure to decrease the cortisol level. There is no change in the cortisol level. So that is another investigation. To find out if the depression is because of the drug, okay, we have got certain drugs or alcohol abuses which can contribute to depression. So we do a toxicology test to find out if it is a drug-induced depression. So these are the investigations that we'll be doing in the depressed clients. Right? So you have seen what is the reason, what are the clinical features, or how to diagnose a patient with depression. So I will continue the treatment in the next video. Hope you all have understood the topic. Thank you.